Welcome to our roundtable. Today we're chatting with Vikas Garg, Principal at ZS Consulting, Vimbai Mudimu, Associate Principal at ZS Consulting, and Michael Lunzer, the CEO of Itiliti Health. Welcome.
Thank you.
We're excited to talk a little bit about technology, health equity, prior authorization, and some recent CMS rulings. But before we dive in, Vikas, would you mind giving us a little intro to who you are and what you do?
Yeah, great. Thanks, Courtney. My name is Vikas Garg. I'm principal with ZS Associates in our health plan and provider practice. And as part of the practice, I lead our what we call value offerings. And those are the offerings that focus on helping payers and providers manage cost and quality of care.
Wonderful. Thank you. Vimbai?
So my name is Vimbai Mudimu. I am also with ZS. I work very closely with Vikas in the health plan and provider practice, also focused on value, which for the last 20 years of my career focused on care management, utilization management, quality, and health equity.
Wonderful. And Michael?
Thank you, Courtney. I'm Michael Lunzer, CEO and founder of Itiliti Health. I am a serial entrepreneur and a few years ago spent some time at Blue Cross Blue Shield of Minnesota. And while there, found some really exciting things that were being done in the prior authorization space. And collaboratively, we developed those solutions and put them out into a separate company called Itiliti Health. And we're really focused on helping health plans and providers streamline the prior authorization process, and look forward to talking with you more today.
Well, you all offer some different insight into all of these topics that we're going to dive into. But recently there was a regulatory update released by CMS relating to health equity and utilization management. So before we dive into the full conversation, Vimbai, would you please give us an overview of what this means?
Yeah, absolutely. So happy to do so. So first, let me just start with what the CMS regulation is. Starting in 2025, CMS is going to require Medicare Advantage plans to add a health equity expert to their utilization management committee. They're going to require an analysis, a health equity analysis on their utilization management rules and outcomes. And they're also going to require that these results get published. Now, oftentimes when we hear CMS regulation, right, we immediately think of the administrative burden that is associated with that. But I actually think it's the right thing to do. And why is it the right thing to do? Because there is growing concern and actually growing evidence that prior authorization leads to healthcare disparities. And so health plans really need to focus on this and take a closer look at their prior authorization rules to make sure that they're not leading to healthcare disparities. This is a topic that I've actually been really passionate about over the last couple of years. And I'm actually really excited that it's now on the forefront and it's something that we can focus on. So just to give you just two specific examples for why this is important. One, there was a study done in 2020 of individuals diagnosed with HIV and the use of PrEP. And what they found was that there was more prior authorization requirements in the South of the US compared to the rest of the US. There is a larger population of individuals with HIV who are Black in the South. So this is a tangible example of where prior authorization was not equally applied, leading to marginalized communities being at a disadvantage. What this does is it just creates more and more mistrust in the healthcare system that we really need to address. So that's example number one. Example number two is in marginalized communities, we generally tend to find that providers have less staff that are available to do prior authorization requests. And so as a result, we find that providers end up prescribing alternative treatments because they're avoiding the administrative burden for prior authorization. Again, adding to the mistrust in the healthcare system. In some instances, we also see increased denials because not all of the information is appropriately submitted, again, because of not having sufficient staff to really do the prior authorization process completely. So all of these factors and just a couple of examples that I shared really speak to the importance of addressing health equity in utilization management. And so I think this CMS's mandate, while yes, it is an additional requirement that health plans need to focus on, but again, and I'll reiterate, it is the right thing to do.
I think that brings up a lot of pertinent questions that we can dive into. But first, let's talk a little bit more about what this means for payers. Why is it important to make health equity as it relates to utilization management a regular and ongoing discussion and not something that we talk about once and create a policy for and then put it on the shelf?
Right. Yeah, so absolutely. So very, very important for payers because what this ultimately what this leads to is poor outcomes and increased cost, right? So I mentioned previously that um, a lot of these issues lead to mistrust in the healthcare system. What that means is that marginalized communities end up abandoning care, abandoning treatment, and not pursuing, the right treatment in order to manage the conditions that they have. What ends up happening is that individuals end up in emergency rooms, they end up in inpatient facilities, which could have been avoided had they, gotten the right treatment at the right time. So this is really important for payers for a couple of reasons. One, it's really important to really make sure that their members are receiving the right care at the right time in order to drive improved outcomes. And two, ultimately, that ends up leading to managed medical cost, where we're avoiding unnecessary inpatient medical spend, which we know is extremely expensive.
Yeah, I'd just like to add that, in addition to the regional disparities around prior authorizations and there's some really big challenges for the patient themselves when it comes to prior authorization. And so people's social economic backgrounds or healthcare literacy backgrounds can have a big impact on their ability to advocate for themselves within the prior authorization realm. And so I think it's great that organizations are being required to report on the outcomes as it relates to equity, because information will help us to figure out where are these challenges and what can we do to address them. Without information, it's really hard to address a problem. And so it'll be great to see additional reporting that can help us zero in on what some of the challenges are.
So, how can payers take the next steps to make the conversations they're having around health equity part of their utilization management plan?
I think my first comment is that payers really need to start acting now. Don't wait, right, until the mandate is here and then you're scrambling to figure out, how to put the measures in place. So I would say two actionable steps that I would encourage health plans to take now is one, add your health equity lead to your utilization management committee. We know that that's coming. Most health plans now have, a health equity lead. We're seeing a lot of great activity in the care management world, as well as in the benefit design world. So I'm excited to see, some activity now in the utilization management world. Second is start to set up the infrastructure to be able to do the analysis that's needed to show the outcomes as it relates to health equity for utilization management. We know that a lot of times, data is a challenge. And so it's really important to make sure that you have the right data infrastructure in place so that the results are meaningful in order to drive change. And what I would say is, this really should go beyond just reporting to CMS, right? And really use the information to see how you can drive change, for your members to really see positive outcomes.
And to add to that, I would say, I think the CM is doing that for a reason. I feel like they believe that um, it will shine some light on the inequities. I think starting early, payers can probably find maybe some of those embarrassing findings now, and then maybe take action on them versus waiting for 2025. Um, uh, just because, I mean, the process is highly manual today, and there's a bias that's probably seeping in. I think it's important to um, to start early and maybe before this have to report it.
How do you think that payers could start developing a strategy around this? Who should they get in touch with to start developing that strategy? And maybe who on their team should be involved in that strategy?
Yeah, no, great question. So we at ZS have actually developed a solution that is designed um, to analyze health equity outcomes on utilization management. And so we have a team that is ready to partner with health plans to implement this. I would say from the health plan side, the people that are important to get involved, really to bring to the table, is first, of course, the utilization management team, right? But also your IT analytics team, as you think about, the data infrastructure that needs to be put in place. Your regulatory and compliance teams, right? So you have the processes in place to do the adequate reporting that is needed. And then, also your provider engagement teams, right? As you think about, and your medical directors, as you think about, the results that come out of the analysis and the need to take action, if there's action that needs to be taken with your provider networks, you want to make sure your provider engagement teams are ready to work with your providers to really make change or drive change.
And I would add one additional thing. We're starting to see RFPs coming out from health insurance companies around the UM area. And I would encourage them to expand the scope of their RFP to add some health equity reporting and overall reporting on utilization management as part of their RFP questionnaires. The reason we partner with ZS in this realm is because we think that, the more we can address a comprehensive solution in the utilization area, the more effective health plans operations will be. And the reality of the scope of utilization management is that there are just so many various parts to the process and to the systems and the ecosystems that the ultimate solution is going to have to be a multi-vendor, multi-partner implementation. And so the more health plans can understand how those partners align and what pieces they deliver, the more effective their ultimate solution will be.
Mm-hmm. Great.
So in addition to health equity, what are some of the top level conversations happening right now in healthcare?
Yeah, so I'd like to answer that if that's all right.
That sounds great.
Okay, so I think again, going back to my last comment, a major topic of conversation right now is how utilization management is affecting the overall relationship between payers and providers. We're starting to see a lot of conversations about provider systems potentially opting out of networks because of the burden that is being placed on them. In some cases, we're seeing complaints about how AI is being used to automatically reject prior authorizations or lean towards the rejection of prior authorizations. And so ultimately it kind of comes back to the last few years where we've seen a lot of provider burnout from COVID and the retirements that have happened in the provider systems. And so it really behooves the health plan payer world to deliver an efficient experience to their provider partners. And that's probably a big part of what the conversation is right now. What's also interesting, though, is CMS has proposed prior authorization regulations about a year ago for streamlining the prior authorization process. And I know a lot of people, me included, are watching CMS's website with bated breath, waiting for them to finalize those requirements. At the same time, there's a possibility they may not finalize those requirements. And so it's really important that health plans not wait for that final ruling and start to take some initiative, because the pain that's being provided or put upon the provider community is real. And we are also starting to see the legislatures, both the state and federal government elected officials, starting to recognize the pain and the angst that's being foisted upon the ecosystem. And so it's really important that the payer provider communities get together and solve this, or they're going to be forced to solve it. And usually those solutions are not always the best.
Mm-hmm.
I've read a lot about the provider burnout recently, and how many physicians are considering early retirement and looking at different opportunities outside of traditional healthcare. But we often see a disconnect between providers and payers within their relationship in terms of how that burnout, maybe it's delayed, how it impacts the payers. So what are some of those impacts on payers as it relates to provider burnout?
Yeah, it's really important, I think, to look at the early indicators of problems rather than waiting for problems to really become significant. So as an example, in a recent survey, 80% of physicians said that prior authorization requirements have been rising and have had a pretty significant impact in the quality of care for their patients. And what's also interesting is they said that not only are the prior authorizations themselves a problem, but 60% of physicians said it's even difficult to determine if a prior authorization is required for a prescription or a medical procedure. So the overall burden is pretty significant on the provider community. And so keeping an eye on that, those early indicators that come through surveys can help payers to really understand how important it is to solve this problem.
So it sounds like, as you're talking about the requirements and some of the components of what both organizations bring to different groups that you work with, it sounds like technology is a big piece of the solution to both of these challenges with prior authorization and with health equity. How do you, Vikas, see AI and automation being leveraged in healthcare to create better outcomes?
Yeah. Well, healthcare is not known to be a technology leader by any means, and it continues to lag. AI, as we all know, has been talked about a lot recently in the news. And according to recent study, healthcare is sort of definitely lagging compared to the other digitized sectors like telecommunications or financial services in adopting the technology. But there is a huge promise of AI uh, for healthcare. We talk about maybe from a promise of predicting the early onset of disease to facilitating decision making to automating manual tasks. For example, scheduling, communications. There's a lot of ways technologies can be adopted by healthcare, and the one big area where specifically for prior authorization is in reducing the administrative burden. Both Michael and Vimbai talked about how the providers are getting tired of the demands on them. The the submission of the prior authorization from a provider to a payer uh, happens to be very highly sort of administrative burden. Um, Once the requests come to the payer, processing all those requires a lot of administrative uh, cost. Um, so, so technology can be a huge facilitator in helping um, both providers be more efficient and effective in sort of submitting those requests once they know what the payer requires, sort of pulling the resources, the, the documentation required, and sending it to the payer, and for the payer to be able to, once the authorization comes to them, to be able to process them in a more efficient and an effective way. So uh, I think that's where there's a lot of promise, and then both payers and providers have been investing in technologies over time, but with the advancement in the AI, especially in the last few years, I feel like that's where the premise and the promise is for both payers and providers to use AI to reduce the administrative burden for both payers and providers.
And I'll just add to that. It sort of connects to what Michael talked about with provider burnout, right? I think ultimately we know utilization management is not going away, right? It is always going to exist, but how do we make it easier and less burdensome so that we're not contributing towards provider burnout, and ultimately members abandoning care? So, Vikas hit on a lot of important points to really leverage, the advanced technology that we have to drive improved processes, improved prior authorization processes, to make it easier. And just connecting to that, provider burnout issue, it has a ripple effect, right? If you mentioned, providers are talking about wanting to retire early, well, that ends up leading to potential network inadequacy issues. So there is a real ripple effect that we really have to be serious about and pay attention to, so that we don't end up in a situation where we don't have sufficient providers to take care of our members.
And I'd like to add one thing about the AI element of the topic, and that is that oftentimes when we talk about the impact of AI on these areas, we kind of use AI and technology synonymously, because AI is the impetus for people to say, how can we address and improve our processes? The reality is that oftentimes AI isn't a necessity or isn't even applied in certain portions of the process to make it better, but it's the impetus for change. And there's a bit of a double-edged sword there. We've started to see some people involved in health plans on the regulatory side, when they hear AI, get a little nervous. So it's really important that we continue to maintain the benefit of AI as a topic, but also realize that it doesn't have to be the true AI of scary movies, right? It can actually just be good technology. It doesn't have to be AI. AI is a intelligent rules engine. So we can add things to the process that are technology driven, that are good uses of technology, and AI may or may not be a part of the actual pieces of the process that people are using.
It's interesting that you bring that up because one of the topics that we've been talking a lot about recently is touchless prior authorization. And most people assume when you say touchless prior authorization that you're talking specifically about AI, but that's not always the case. So what does touchless prior authorization mean? How does it impact providers? And what does that mean for payers?
Yeah, that's a great question. So when you think about the process, right, the first step in the process is for the provider to be able to know, I just created an order, is a prior auth required? There's different degrees of touchless in this scenario. One degree is the current way things can happen, which is a provider goes out to a website and asks a question or determines if prior authorization is required. And the easier that process can be, the least amount of work for the provider, can be called touchless. The next step of evolution in that process is where the electronic medical record system in the background is asking the payer's system if a prior authorization is required, and showing that up, bring that up on the EMR system in the middle of the workflow, right? So that's the degrees of touchless. The fully touch is where the provider has to pick up the phone and call the payer, right? So there's degrees of touchless just in the determination of, is an authorization required? When it comes to submitting the prior authorization, there are multitudes of systems that will look at prior auth requirements and gather the correct information inside of the EMR to assist the provider in submitting that prior authorization. And then there is the new proposed standard from CMS that revolves around the Da Vinci standard of HL7 Fire, which is ultimately, maybe in 5 or 10 or 15 years, getting to a point where there's automatic submission of prior authorization requests. But again, there are degrees of perfection there. And I think it's really important that organizations look at evolutionary ways to improve these processes to get to touchless and fully automated versus trying to kind of create the perfect scenario up front. We can't let perfect be the enemy of good. And we have to know that healthcare is an evolutionary process. So ultimately, I think we're all headed towards the goal of doctor writes an order, systems behind the scenes navigate and determine yes or no, this is approved, and the doctor gets that message right then in real time. I think we're a long way away from that, but there are things we can all do to get to make meaningful progress towards that ultimate goal of real-time touchless.
Mhm. And just one analogy that I'll add to that is I oftentimes think about the banking system, right? And if you recall, many moons ago, we had to physically go into a bank to do all of our banking transactions, right? And today, you literally never have to see the inside of a bank. You can do everything, from your computer, from your phone, just very digitally enabled. And so, I envision a future where, right, that exists for us in prior authorization, as you mentioned, touchless. But I think the important point to just emphasize that you mentioned is it is a journey, right? It's going to take some time to get there. But in the meantime, we can take some meaningful steps to make progress.
We do see a lot of health plans thinking about this from the perspective of how do we go from the banking world where you had to go into the bank to today's automatic bill payment scenario in a year. And that's really not practical. And that's gotten in the way in a lot of cases of health plans making meaningful impact on this problem, because they're kind of trying to boil the ocean and go from today's very manual world to a future world without taking some meaningful steps in between. And I think that's a really difficult thing to do, and has the potential of making it impossible to accomplish the task, because if you don't make incremental steps, you may never get to where you want to be.
Yeah, absolutely. And just one more point to add to that, which is it sort of emphasizes the point, Michael, that you mentioned earlier about technology and AI, and that we really have to, it's wonderful to have, and it's a perfect time to leverage all this advanced technology, but we also have to be cautious of how we do it. Similarly, with the process, what we oftentimes see health plans do is, oh, there's this wonderful technology that's hit the market. Let's apply this technology and it's going to fix all my problems. Well, you can't, just layer on technology on a bad underlying process, right? So what we really have to do is focus on how do we improve the process, the underlying processes, and then leverage technology to really drive change. And I think that's another, area of opportunity to really partner with our health plan clients to achieve the ultimate goal that we're trying to achieve.
That's a great point. And leading into that conversation about the relationship where both companies work with payers, let's talk a little bit about the impact on payers to incorporate some of this technology that can help improve their systems. So what are some of those administrative cost savings that payers can expect to realize when they implement AI and automation as part of this process?
There are estimates around that 25% of the US healthcare spending is on the administrative burden. So it's really, really expensive today to go through all the administrative processes that both payers and then providers go through. As we talked about technology in general and in AI, with the advent of AI now, there's definitely a promise of reducing that quite a bit. I'm going to talk more maybe on the payer side. There are three places where we see technology and AI can really help reduce the administrative cost. The first one is on the intake side. Is even today, we talk about touchless, and Michael talked about sort of how that's a goal, but not a reality today. There's still a lot of payers get a lot of faxes and phone calls today, and the intake process tends to be highly manual. And as we talked about, the number of prior authorizations continue to increase with the advancement in clinical technology. So there's a lot of requests that are coming in. So there's an opportunity for payers to reduce that intake cost of the prior authorization. Number two is more on the processing of the decisions of the prior authorization. So clearly, there's clinical staff that takes a look at all those requests coming in and makes a decision on whether to approve or deny that particular prior authorization, and that requires a lot of manual decision making today. Where there is definitely a way for technology to solve the triage the problem, where maybe some of the low complex decisions can be done, can be automated, whereas sort of and making the staff sort of more, and leaving maybe the more complex issues creating the capacity for the staff to work on more of the complex issues. So there's definitely on this the second process. Number third is the communications back of the decisions. Even that today is highly manual, where physical letters getting generated and going from a payer to provider. So automating that process, integrating with the EHRs and so forth.
Yeah, I would add that, in terms of the outcomes and the impact of these solutions, I mentioned earlier that just by effectively sharing prior authorization rules and policies, health plans can eliminate 30% of the burden of prior authorizations. And it's such a simple, obvious step, but the complexity of prior auth rules and policies makes this daunting for health plans. Many health plans have a simple CPT code lookup tool on their website, but they're still not effective. Or they'll publish, even worse, a spreadsheet listing by line of business of what CPT codes require prior authorizations. So by effectively delivering a better solution there, we have found, for instance, our PA checkpoint product, which gives the date-specific, patient-specific CPT code and medical policy rules. We can eliminate 30% of all prior authorization requests and 20% of all provider calls. That's just unbelievable how simple of a step it is and how much of an impact it has, and how many health plans are saying, well, we want to fix the whole problem by automating the entire process. Well, that's wonderful, but let's start by accomplishing this versus waiting 5 years to solve the entire problem. And this is a logical step towards solving the problem. Another bit of feedback we've heard from health plans is that just by organizing the process of looking at medical records and comparing them to medical policies and creating an effective documentation for live users, we can decrease the time and effort around prior authorizations by 50%. And of course, we want to eliminate 90% or more of that work. But there's this low-hanging fruit of 50%, that if we can eliminate 30% of all prior auth submissions, organize the prior auth process, and eliminate 50% of the pain, imagine what we could do with the people and the resources that are left, and incrementally get to that 90% touchless, perfect prior authorization world. So that's what to me is exciting, is the opportunity to make a difference today with solutions that are relatively easy to implement, and at the same time know that there are these, a little bit more difficult solutions coming that can get us to that 90% streamlining, but we need to start today, rather than hiding behind the uncertainty of, well, there might be a better thing coming, so we should wait. And another economic analysis that I heard recently, in terms of transactions between payers and providers, claims and eligibility transactions are almost 100% electronic, right? These are, everybody thinks of those as being, very automated, but prior authorization transactions are extremely manual and are cost anywhere from $30 to $70 per prior authorization on each end of the transaction. So this is an area that's ripe for opportunity to solve it and save money and improve patient experience. And so it's an exciting time, but it's also a challenge for health plans to make sure they don't let perfect be the enemy of good, and that they incrementally solve this problem rather than delaying another 5 years while they wait for the next regulatory requirement.
So as we're thinking about these different types of technology, how can your companies work together to help clients implement solutions or create solutions for some of the challenges they're facing?
So I can start with, I think what Itiliti Health has been doing is talking with ZS and other companies in the ecosystem to make sure that we are all coordinated in the way we can work together to solve this problem, both from a technology perspective and from a customer or a health plan interaction perspective. I should mention, I have a tendency to talk about prior authorization from a payer perspective, and that's because Itiliti Health is really focused on the payer systems and the payer infrastructure. There are a lot of things being done on the provider side that we anticipate or expect there to be more of a transparent connectivity between the two. So again, from our perspective, it's working with companies like ZS, and we're partnering to help deliver really strong analytics along with transactional processes. So Itiliti Health being the transactional processes, ZS being the analytics that can ultimately get a health plan much farther along in the process. And so that's the Itiliti Health perspective. I'm curious to hear your perspective, Vimbai and Vikas.
Yeah, maybe I can start. I completely agree. I feel like it is a very complex problem, as we've been talking about for the last over the last hour. And the solutions will require different brains and different skill sets to come together. And that's where we see an opportunity for ZS and Itiliti to work together, because we, as Michael mentioned, we are definitely working on the different steps of the process. While Itiliti is focused on creating more transparency around the payer requirements from a payer perspective, and then helping providers sort of reduce the burden based on just knowing what the prior authorization requirements are. We at ZS have worked on multiple solutions. One of the solutions we have worked on is an analytics dashboard, which helps payers identify sort of the overall health of their prior authorizations operations, and we provide recommendations based on the industry benchmarks on how can they make the process more effective and efficient, both from a labor and non-labor perspective. And then we also supplement our analytics solutions with services, ZS being primarily healthcare services company. We can come in and help implement those recommendations for our payers and provider partners.
Yeah. And I think just to wrap up, because I agree with, Michael and Vikas overall, I think where I see the power of ZS and Itiliti Health is that we really combined our end-to-end. And so we together become a one-stop shop where we can work with our health plan clients on this transformation journey. And it truly is a journey, right? And, we've really thought about the steps that need to be taken to achieve success. And I think together, we can partner and work together to drive change for our health plan clients.
Well, it was wonderful to chat with all three of you today. We will add all three speakers' contact information on the last slide and also in the notes of this presentation. Please feel free to reach out to any of them with questions, and we will see you again soon.
Thank you.
Thank you.